Welcome back to the podcast. I am joined today with Dr. Michael Cummings. He is going to be talking with me today about social anxiety disorder. And we will get into probably some of the things going on that lead to social anxiety disorder, genetics, neurobiology, brain stuff, along with treatments. And I'm looking forward to this discussion.
Yes, indeed. And I'm happy to be back to be talking about this. We sometimes don't seem to focus enough on the anxiety disorders. As a group, they are the most common type of psychiatric disorder, but they receive less attention in general than things like major depression and schizophrenia and bipolar illness. And of course, social anxiety disorder is one of those disorders. The prevalence numbers I found in the US population seem to range from around 8 to 12% of people at some point meet criteria for social anxiety disorder. A little more prevalent in women, a 4-to-3 ratio, women to men. And indeed, the core of the illness is either fear of being scrutinized or fear of performance, which indeed those often go hand in hand. Can be very disabling for some people in terms of preventing them from being able to do things in their life that they would like to do, but they are too anxious to pursue them.
There's something, it's like the anxiety rises to a level in which they stop doing the things that they might enjoy or may need to do because of social aspects. And with children specifically, it's around other children that they will have the increased fear. And if it's just around adults, that is not considered social anxiety for children, but if it's around other children, then it could be considered social anxiety.
Yes. And indeed, people who have looked at this in terms of its evolutionary history, clearly human beings benefit greatly from being a member of a group. We're not highly effective at doing things all by ourselves. And in many ways, a lot of those theorists have hypothesized that social anxiety disorder really comes out of a fear of being rejected by the group that one would like to belong to, which of course makes sense. All of us need other people, need social connections, and it to some extent, anxiety over being accepted or rejected, of course, is a normal part of life. The people who suffer from social anxiety disorder, though, as you point out, their anxiety rises to the level that it begins to inhibit their behavior. They begin to be unable to make social approaches.
They start to avoid important events and activities such as classes and meetings. And then as they progress, they may be less likely to have meaningful relationships like getting married. And then as they progress, it's like the more they avoid, the more it kind of reinforces the anxiety.
Yes, indeed. The people I've treated with this often start with a relatively modest amount of fear about a particular activity or performance, but the more they avoid it, the bigger the danger of that activity becomes in their mind, to the point where they it reaches proportions well beyond what is realistic.
Yeah. So I think this is an important topic to go through. And I know on the podcast, we've talked a lot about schizophrenia and psychosis. And then I was looking through our episodes we've done together, and I was like, we really haven't covered anxiety.
Mhm.
not much. And so I think this year we'll try to cover some of the different anxiety disorders. And this will be the first one in that series. So
Yeah, indeed. And I think that's good because people, as I said, psychiatry tends not to pay enough attention to this area. It's also important to take a look at because, of course, DSM-5 kind of reformulated the class of anxiety disorders. They removed obsessive compulsive disorder and post-traumatic stress disorder from the anxiety disorder categories and put them in their own category. And they added separation anxiety and selective mutism to the anxiety disorders, along with generalized anxiety disorder, uh, specific phobias, and social anxiety disorder, as well as panic disorder. And it's an interesting group of disorders to discuss and think about. So I think from that standpoint, it'll be good over this year to talk about the anxiety disorders.
are there any other sort of diagnostic questions that you might ask to pull out if someone has social anxiety disorder, or things that you might hear in the history that make you think that they might have social anxiety disorder?
Um, yeah, the question I often start with, and it's a paraphrase of a question that occurs in the Schedule for Affective Disorders and Schizophrenia. I usually start by asking the person if there are any situations that make them anxious enough that they avoid them, rather than starting with, are you nervous? Are you anxious? Or is there anything that makes you uncomfortable enough that you avoid it? And then I'll give them example things like public speaking, or um, performing in public, or going to a gathering where there are a lot of strangers. And that usually then starts the conversation um, about the disorder and its symptoms, and it opens the door and allows the patient then to talk about what they may be avoiding in their life. Because what I'm trying to get a sense of is how avoidant has this anxiety made them. Because that's really the crux of the disorder, is that the anxiety is bad enough that people avoid things in their life. And then of course you always ask about the common comorbid conditions. The anxiety disorders very commonly co-occur with episodes of depression. May also people may at times have a primary anxiety disorder, but occasionally they'll have collateral anxiety disorders as well, such as panic, or now agoraphobia has become its own disorder in DSM-5. You could consider agoraphobia sort of the extreme end of social anxiety disorder in some ways. As well as, I always ask people about simple phobias. Are there specific objects or creatures or things that they are so fearful of that they avoid them at all cost? So over time, you can get a nice overview of the person's anxiety, because in terms of the underlying physiology, um, us as a species, we're not huge, big predators with sharp teeth and claws, and consequently, we spent a lot of time avoiding predators that were bigger than we were. And it paid to be aware of our environment and to have some degree of anxiety or fear to drive vigilance. And for us, that's mostly the lateral and inferior portions of the amygdala and the temporal lobes, along with the temporal poles, are in many ways in sort of charge of looking at the environment and looking for danger. That is then routed through the hippocampus and parahippocampal complex, and also then involves ascending circuitry to the anterior cingulate gyrus and the prefrontal cortex. That sort of then completes the loop with communication back down to the amygdala about whether what it has perceived is really dangerous or not. So in many ways, all of the anxiety disorders that are now in this group, in the DSM-5, share that same circuitry with variations, basically.
I was looking at a paper that reviewed a bunch of the resting state MRIs. Mizzi et al. 2022. And what they found was very similar to what you were saying there, that there's this increase in connectivity between the amygdala and the prefrontal cortex, which plays a significant role in controlling attention to salient stimuli and emotional regulation with the presence of this, so imagine if this is charged up, you may be, having increased attention to more things. Anything about the amygdala and the prefrontal cortex and how they interact that comes to your mind?
Yeah, when in the healthy person, I mean, obviously, again, thinking about our ancestors, it's useful to know whether that set of stripes that just walked by in the tall grass was a tiger or not. And it's good to figure that out before you become lunch. And in part, the amygdala sort of serves as the monitor. Is something dangerous? The anterior cingulate and the prefrontal cortex both direct attention, and then the prefrontal cortex is the part that makes a judgment about, well, is this thing really dangerous or not? If not, it can then inhibit the activity of the amygdala. When that's not inhibited, the anxiety can grow to the point that it sets off the classic fight-flight response. And indeed, that's, the physical signs and symptoms of the anxiety disorders, including social anxiety disorder, go along with that: increased blushing, increased sweating, tremor, increased heart rate, blood pressure. Those are all essentially arousal symptoms for the sympathetic nervous system is being overdriven at that point.
So you get this hyper alertness, this like danger, which, maybe has a survival advantage in a lot of situations. And, like thousands of years ago, maybe it would have had quite a different survival advantage than today. It's to think of your anxiety as less of an enemy and more of like a little buddy, a buddy that's trying to keep you safe. And it's like, part of the treatment, I think that's effective in psychotherapy is can you, instead of avoiding the anxiety and listening to it to the point of avoiding what you're afraid of, can you like have compassion for that part of yourself that's, your little buddy that's over aroused, over concerned, like that maybe kept you safe early on, developmentally even. And can you have compassion for that side of yourself?
Yeah, indeed, very much so. And that's, the two psychotherapies that have been most evidence supported for social anxiety disorder are cognitive behavioral therapy, which works on just that, rethinking the anxiety and essentially, in part, converting it from something the person finds onerous and difficult to reconceptualizing their anxiety as a useful monitoring of the environment, and also then though testing, is this situation really dangerous, or not? And over time, sort of retraining their anxiety, if you will, not to be quite so apt to respond to things that are non-dangerous. The other therapy that's been highly and widely used for a long time, of course, is exposure therapies, behavioral therapy, in which the person is exposed to the fearful object or situation in a graduated manner so that they can master the anxiety. And in a way, it's an alternate approach to essentially training those anxiety centers not to be overly responsive in non-dangerous situations.
Yeah, I was looking at this data to prepare for this, and there's one study in particular that looked at cognitive behavioral therapy versus more of a psychodynamic approach. And they were pretty similar. Maybe the cognitive behavioral therapy a little bit better. I'll put those in the notes if you want to look at that study. And then there's other studies looking at like acceptance commitment therapy versus cognitive behavioral therapy. Pretty similar. A slightly different approach in the acceptance commitment therapy. They may look at your values and utilize those values as part of the treatment, but also then more of a mindfulness approach to the anxiety, looking at it and being curious about it. Maybe not trying to like cognitively attack it like in a CBT model, but can you just like more appreciate it? Very similar outcomes in most psychotherapies, which means most psychotherapies can be helpful.
Yes, indeed. Which is an important point, because given the prevalence of social anxiety disorder, well, the stated prevalence is probably an underestimate, because a lot of people with milder social anxiety disorder don't ever seek treatment. And unfortunately for them, that winds up robbing them from being able to do or enjoy things as much as they should. So certainly people should be encouraged to pursue treatment for this. If people are out there listening and they have anxiety that's sufficient to make them avoid things in their life, they really should consider therapy to overcome that, because otherwise they're just denying themselves part of their own life.
I think that one of the common sort of pathways that I see is you have a kid who starts to get anxious and will start to want to withdraw from social interactions. And at times the parents like co-opt this, and they are like, oh, okay, I'll pull you out of school and I'll homeschool you. And, it's so then the kid for 4 or 5 years is homeschooled, and it's like progressively more and more avoidance. And then at some point the parent is like, wow, maybe I need to get some professional help for this. And so sometimes it's like 5 or 6 years down the road when you get a good history that this person has suffered without now normal developmental relationships. And so it's kind of like they're rebooting later in life. And that's where, I see some of these patients. And yeah, any thoughts on that?
Yeah, I think that's something parents need to be especially careful about. Certainly, I think every child has some degree of avoidance. I mean, everything provokes a little bit of anxiety when it's brand new. Those people, though, who do withdraw and become essentially isolated, the patients like that I've treated have a very difficult time later in life, when you can't be homeschooled forever, because if you progress in school, eventually you're going to have to go to either high school or college. And without the social interactions growing up and the development of social skills that they need, they have a very rough time when they try to venture out into the world, to the point that some of them essentially have a very difficult time functioning in such settings, because they haven't had practice. They haven't dealt with either being accepted or rejected, and consequently they're not emotionally and intellectually prepared for those things.
One aspect, the DSM, when they usually describe things, they don't talk about like what's really going on in the inner, like in the inside of someone, but often what I find in these patients is they have a very strong negative narrative about how people are viewing them,
Yes.
and how much shame they have based off of these narratives. And so like tying this back to the neurobiology, in this one study they were looking at the fusiform gyrus and how they look at faces, and how there may be actually a mischaracterization of people's faces, which like maybe seeing more negative emotions out of people, which are not necessarily intended to be directed at them. And so you have these people who can be very competent in a domain of their life. Maybe they're a lawyer or a doctor, yet because of the negative attribution of what other people are thinking or feeling towards them, it just cripples them socially.
Yes. Indeed, there have been a number of such studies where they show individuals a series of faces, many of which are neutral. And indeed, people with social anxiety disorder attribute anger or hostility or other negative emotions to faces that were intended to be neutral in character, and that people without social anxiety disorder do interpret as neutral. And that fits. There's an over attribution of, oh, I'm being scrutinized, I'm being judged. They've even tracked that down to things like people with social anxiety disorder characterize their own blushing as much more severe than it actually is when it's being measured objectively by temperature change. The thermometer says their blushing is mild. They see it as, oh my God, I've turned bright red like a lobster. So there's a misinterpretation of their own anxiety. And to some extent, particularly in the performance-related version of social anxiety disorder, because they are sweating a little more and they have a little bit of tremor, they in essence then become anxious about being anxious, and it becomes a very vicious positive feedback loop for them.
Right. So imagine now this very sensitive to other people's experience of them, someone who has heightened sensitivities to that, now trying to seek care by a psychiatrist or therapist. Now you are the therapist or psychiatrist listening to this, and imagine that they will think that you are thinking critically of them, or that you are thinking something maybe that maybe disgust or shame evoking, inside of them. And so this is where I think maybe the transference work, or just being aware of the interpersonal, being aware of the here and now, can actually allow you to put words to this if it comes up, and then move through it so they can actually stay in treatment.
Yes, indeed. And the other thing is, when people have been on this path for a while, which many of them have, by the time they come to treatment, although we haven't devoted nearly as much research effort to pharmacologic approaches for anxiety disorders as we should, there are a number of pharmacological agents that can help reduce anxiety to a manageable level, so that the person can then be more effectively available for psychotherapy. That's a theme you've heard me say before, that the role of medication in many of these disorders is to make the person available or more available for psychosocial treatments.
Yeah, I think both of us have this balanced view. There's going to be people who listen to our podcast, and I know there are, that are pure psychopharmacologists. They imagine that most of what they do is psychopharm,
Mhm.
and those people who have patients who are just on medication, they need to continually find ways to educate their patients on the importance of doing the work, psychologically, psychotherapy wise.
Mhm.
And then we have listeners as well who are like, they go to conferences and they hear about the evils of big pharma and their very anti-psychiatry colleagues. And those people need to be informed, like, well, if the anxiety gets to a point where it's so high that, the patient can't do any behavioral experiments, they can't venture out, or that, it's like they can't even take the first steps, or even the work in sessions is like, it's very, very hard to access what you need to access. That's when medications can have an important role. So,
Yeah, very much so. And certainly for social anxiety disorder, the SSRI antidepressants and the SNRI antidepressants have been the mainstays of treatment for a number of years now in terms of evidence-based treatments. People have gotten interested, and of course, before that, at least for short-term use, benzodiazepines have been used, although those have a lot of potential problems in terms of tolerance, risk of abuse or dependence, withdrawal. And then, more recently, beyond the antidepressants and the benzodiazepines, people have gotten interested in a variety of molecules in terms of potential approaches to reducing anxiety. Not a great deal of research has been done, not enough. But people have started looking at things like cannabidiol, one of the two psychoactive components of marijuana, cannabis. They're two delta 9 THC is what makes people high, and in some cases makes them paranoid.
mm.
Um,
On that one in particular, I looked. There was this 2022 study
mhm,
called "Cannabidiol Enhancement of Exposure Therapy and Treatment of Refractory Patients with Social Anxiety Disorder and Panic Disorder with Agoraphobia," a randomized control trial.
mhm,
And they found in the first clinical trial examining CBD, cannabidiol, as an adjunctive therapy in anxiety disorders, CBD did not improve treatment outcomes.
mhm.
So that was, I don't know if you've read other things that make you
I've
more
I've
hopeful.
I've read that. I've read that study, and I think the um, at this point there needs to be more research in this area. The interest largely came from animal studies where
Okay.
um, things like the elevated maze test was better tolerated by mice who had cannabidiol on board. So essentially it's an animal proxy for anxiety. But again, this is an area I think that needs much more research. There was also, I believe, a 2019 study which actually used cannabidiol as an adjunctive treatment in individuals with schizophrenia. Interestingly, they found in them it did have a not huge but significant effect on reducing both psychotic symptoms and anxiety.
Hmm. Yeah,
Uh,
I've seen some positive stuff for schizophrenia. That's interesting to
so
me.
I think this is an area where there needs to be more research uh, so that perhaps we have a better understanding of how the endogenous cannabinoid system interacts with the amygdala in terms of modulating its activity, and see if there are specific circumstances and amounts and doses that might be useful in some people. We don't know that yet, so I'm certainly not recommending cannabidiol for current treatment of anxiety disorders. People have also looked at the neurohormone oxytocin, which, again, clearly in animal studies reduces anxiety-like behavior. And in humans, it's been tested well enough to know that it promotes social interactions, essentially increases trust, and in some animal species like voles, pair bonding. Again, needs much more research though, in terms of could it be a potentially useful treatment for anxiety disorders?
Yeah.
This is sort of my soapbox of, we need to pay more attention to this area and do more research.
I think one article that I really enjoyed reading and gave me a lot of insight into the treatment of social anxiety was this article I sent you, Dr. Cummings, on a randomized clinical trial by Frick et al. 2021, in which 27 patients with social anxiety disorder were divided into two groups. One group was verbally told that they were going to receive the effective drug Lexapro, while the other group was told that they were going to receive a non-effective neurokinin 1 receptor antagonist that would have the same side effects as Lexapro, but none of its benefits. And so in reality, though, this was a deception study. In reality, both groups were given Lexapro 20 milligrams. And the idea was that they would look at, did the expectancy of having the real treatment change the dopamine and serotonin levels as measured by PET scans with radio tracers, and would the expectancy change the outcomes, like a greater decrease in social anxiety? Okay, so the findings were, in this study, that the individuals that were told that they were receiving the real medication, remember, both groups were actually receiving the real medication, escitalopram, Lexapro, but specifically, the individuals that were told that they were receiving escitalopram, Lexapro, and were receiving escitalopram, Lexapro, that group had significantly lower dopamine transporter binding by the radio tracer in the striatal and thalamic brain, meaning the actual dopamine in the brain was releasing slower from those dopamine transporters, leading to better outcomes due to expectancy. So let me put this another way. The radio tracer in the PET scan was trying to bind to the dopamine receptors. And in the group that received the Lexapro and was expecting a good outcome, their brains had more dopamine naturally binding to those receptors. And so the radio tracer could not bind to those receptors as well. Okay, and they believed that this expectancy actually led to the good outcome, that the group that thought that they were receiving the real medication had a larger effect size and decrease in social anxiety symptoms. The effect size was pretty significant in the group that thought that they were receiving the active medication. It was 2.3. In the group that thought that they were receiving a placebo, but were in reality receiving escitalopram as well, it was 0.93. So both of them did well, but the group with the expectancy did a lot better. And it had to do with increased dopamine being released. Okay. And just a side note, in this study, when they looked at serotonin changes, they didn't see any difference between the two groups. Probably because, they had a serotonin reuptake inhibitor. So there was an actual change being caused by the medication that was leading to pretty equal things going on in both groups. Overall, the study highlighted to me the significance of expectancy and belief,
and how treatment is highly influenced by the faith one has in a given treatment. Any thought on the power? I mean, it seems like there's such a power of placebo in this study and the way that they showed it.
There was, and indeed that's been one of the issues in anxiety disorder research for a long time, has been that there's often a fairly high placebo response rate in those where placebo is used. Even, just taking a socially anxious person and putting them in a research study where the staff of the study are supportive and friendly, that in and of itself can sometimes alter the results. So that it in some ways it makes anxiety disorders more difficult to study from a pharmacological perspective, because you have to be very careful not to assume that it's the pharmacology of the drug that is indeed changing things. Anything that is reassuring, such as, oh, I'm taking a medication that will help me be less anxious, that thought in and of itself indeed may make the individual less anxious.
What do you think about the okay, so in defense of medications, like both groups had a decrease in the symptoms.
Yes.
It's just that the group that thought that they were taking an actual substance had a bigger drop, right? And so even taking what they thought was the placebo, in this case, an active control, decreased the social anxiety, levels, and to a place that may have, clinical relevance too. In my mind, it's like, okay, if your score is coming in at 80 and now they're down to around 60, the other group is started out at 80 and now it's down to 40, but that's still a significant drop out of 100, where maybe they're able to better tolerate therapy. But anyways, so I'm kind of thinking out loud, like, I'm not saying that we shouldn't think of medication as, as a treatment, and I definitely would consider it a treatment. Just that there's something about anxiety in particular where the expectancy actually is changing the brain.
Yes. Well, and indeed, in some ways, we've come back to the issue that, the amygdala, hippocampus, anterior cingulate prefrontal cortex circuit is there basically to monitor whether you're safe or not. And if you indeed are having the thought that you're safe, well, that in and of itself changes the activity of that circuit.
Yeah. It's and so if you think you're safe because you're taking a medication, that changes potentially your reactivity just by the thought, like, okay, I'm proactively doing something for myself. I'm taking a medication and this is going to help me.
Yes, indeed. Which is, which can be very useful. That's one reason in children, for example, sometimes having a transitional object for a new social situation can be very helpful. I had one young patient who, as long as he had his special marble in his pocket, he was much more comfortable at school. Now I have, that glass marble was not directly doing anything to his brain itself, but his feeling reassured by having this familiar, comfortable object in his pocket altered his anxiety response. And in some ways, a pill can do the same thing. I think sometimes we underappreciate that medications always have two components. One, the actual pharmacology of the medication, and two, be it positive or negative, the person's attitude toward taking the medication.
Right. And their attitude towards you as the one that gave them the medication, I think is powerful as well, because if they trust you, and if you've given them more possibly than medication through psychotherapy, the medication has in and of itself like a bigger impact and a different meaning than maybe someone who feels very disagreeable towards their provider.
Yes. medications can have an element of being transitional objects or gifts from somebody who cares about them.
Yeah. Yeah. I think the other, with like, I think we should talk a little bit more, maybe even about the behavioral aspects of like how you might like decrease someone's behavioral, or, through a behavioral approach, how might you progressively decrease someone's anxiety? Like, let's say they're anxious about going to school.
Mm-hmm.
What kind of thoughts do you have around what you might recommend as a progression towards that?
And I'm not a behavioral therapist, so I'll say that up front. What I have learned from the behavioral therapists I've worked with, though, is the first step is to more clearly identify what specific elements of going to school provoke anxiety, and then to break those down into a hierarchy from that which produces only a mild anxiety response, all the way up to the thing that would essentially would make the person want to flee in terror. And then starting at the very low end with manageable anxiety, essentially either in imagination exposing the person to the low end of the list in terms of what provokes anxiety, and helping them work through that by repeated exposure until it no longer makes them anxious, and then moving up a rung on the ladder, if you will, until they can get all the way up to the point of actually conquering the thing that originally would have made them flee in terror. And that core approach seems to be highly effective when it's being done by a resourceful and talented behavioral therapist. Because I've seen people conquer fears with everything from, indeed, social anxiety disorder, where the person was able eventually to do the thing that they were initially feared so much they were avoiding it, to simple phobias where people might be, say, afraid of a lizard, and they start with imagery, and they finally get them up to the point where they can actually hold a real lizard in their hand and not be panicked by it.
There's a couple like common things that I get where we could look at this and give it some examples. Like, one would be dating. I've met a lot of people who have a lot of anxiety around dating. Let's say you're a guy in your 30s and you have not dated for years and years, right? And like, just the even thought of approaching a girl and ask her out on a date is like very anxiety provoking. And so, I like that approach that you talked about, where it's like, okay, what are the 10 aspects? Can we break it down even further, right? Dating itself into like 10 aspects, and which of these 10 is the most anxiety provoking and the least anxiety provoking?
Yeah, creating a hierarchy so that you can start with the least anxiety provoking, and the person can then work their way up.
Yeah. And then how do you essentially give homework, and then they're running an experiment of sorts with like trying to do this fear task, starting with the lowest on the spectrum, and if doing it is too much, then starting with the imagination, their imagination, and imagining this,
Mm-hmm.
writing out a story, or imagining in their head, and then progressively moving through it to where they're able to do and practice it, And I think as well, I like the sort of the acceptance commitment therapy stuff, where it's like, can you, one, come back to your values, like why you might value
Mm-hmm.
building a meaningful relationship, and then two, in the midst of the anxiety, can you notice it mindfully and like appreciate it, and not necessarily like judge it or be critical of it, but almost like see the adaptive potential, and see it as, instead of like a monster, see it as like, a little buddy, a little friend who's been trying to help you, protect you, right? Now, it's so idiosyncratic with each individual, right? Because there's trauma that often people have with dating, or there's trauma people have interpersonally that can kind of cloud things.
Mm-hmm.
So it's not always.
Yeah, each person's experiences will greatly shape what it is that provokes an anxiety response for them. Although there are some fairly common ones. I'm always amused. I think it's the New York Times publishes every year a list of things that people fear the most, and public speaking is always up near the top. In fact, it not uncommonly outranks dying. So,
Oh.
so indeed, that's one of those things that a lot of people have a bit of fear about.
Yeah, once in a while I'll ask someone to be on a podcast and I get this, there's this like look that comes over their face of like, you want me to kill myself? Is that what you want? Like, I'm like, no, you'll be having a conversation with me. No one will be in the room but me and you. It's like, yeah, but you'll be recording us. Are you recording us now? If you're recording us now, I need to know.
Yes. Well, again, it comes back down to what we initially touched on. I think for many people with social anxiety disorder is that it's that fear of being scrutinized and judged.
Oh,
And of course, when you're doing something like public speaking, you're intentionally typically standing up in front of a group of people and saying something, and you're drawing attention to yourself intentionally. Well, that's a perfect setup for being scrutinized.
oh my gosh, absolutely. It's
there. I mean, there's a lot of things with public speaking. I think also with like, there's a group of people like in the audience, and it's like, there's something about a bunch of eyes looking at you, which evokes like a strong danger response, right?
Mm-hmm.
It's like historically, it's a very dangerous situation to have that many eyes on you, maybe, or something,
Yes. You don't know if the eyes are hostile or not. And I think it evokes that kind of response, because indeed, if you go back far enough, whether you were accepted or rejected by a group could be a life and death circumstance. And so indeed, having a lot of people stare at you, I suspect, reawakens what amount to some very deeply buried species memories in terms of, why are all these people looking at me? Is this dangerous?
And that, like, for those of you who are listening, you're like, oh, here's Dr. Cummings and Dr. Peter talking in front of people. And, of course they've never struggled with talking in front of people. But I remember like sitting on my podcasting gear for like a couple years and like recording some episodes, but then being so overly critical of myself and like what I had recorded that it just never got released. So it's like, I feel like there has been a behavioral process that I've been involved. I don't know if you felt that yourself with being on here and or public speaking in general.
Not so much for the podcast, because by the time we started doing this, I had been doing public speaking for a long, long time. But I do remember initially it was very difficult. And you always worry about, oh, you're going to say something wrong or make a faux pas. At some point, the turning point for me was when I figured out that in general, the audience is on your side. Because frankly, if you're the person up there talking, they're identifying with you, and frankly, they're to some extent happy it's not them.
Yeah.
And if you are clearly enjoying it and talking not at them, but talking with them, it becomes a much more collaborative, collegial experience, even if there are hundreds of them and only one of you.
Yeah. I think I think I tell myself, like, if someone, that the nice thing is to not have people forced to listen. Like if people find something about myself or yourself, like it makes them so upset that they can't listen, then they'll stop listening. They'll listen to
Yes.
something else. And And so if they continue to listen, it's often because they've self-selected to continue to listen.
Mm-hmm.
So I much prefer to talk to people who choose to listen.
Yeah.
And yeah.
Well, I think for the person with social anxiety disorder, when they can reach the point where they realize that by and large, people are much more accepting of other people than the person with an anxiety disorder realizes, because they're imagining this person scrutinizing me, they're hostile, they think I'm disgusting, despicable. Very seldom are people that negative.
People, I often think people are usually thinking about themselves in social contexts, where it's like maybe they're not critical of you, maybe they're critical of themselves as well. And so like your perception is that they may be anxious about, or they may be critical. Your perception is they may be critical of you, whereas they may be sitting there critical of themselves, thinking about how you're thinking critically of them as well.
Yes.
So it could be like, I think that's more common than the other way around.
Yeah. Then you have dueling anxiety. Yes. But yeah. And I think indeed, when people can overcome that to the point of realizing that no, people are not that hostile, it can help them then be more willing to take the risk to perform in public or talk in public or meet people or eat in public, all of the various forms that social anxiety can take.
Yeah, I find that the here and now work of the psychotherapy and the transference and getting them to talk about if they feel like you're thinking of them critically, or between sessions, they often will, patients sometimes will think like you are thinking critically of them, and then just getting them to put that to words and empathizing with the distress of it is so powerful, because it, over time, they'll internalize someone who cares about them, who is not thinking critically of them, who they can and then through that, they may be able to judge other people's interactions with them more accurately as well. So for example, like let's say a patient has had parents who are very critical of them, and so they internalize this critical internal voice. Maybe that helped them exceed in many domains of life. Maybe they got through medical school because they were constantly berating themselves, thinking they weren't doing good enough. And then they get into their professional life, but then they struggle interpersonally because they are constantly thinking that people are thinking negatively of them. So then they go into therapy, and let's say they are able to put that to words with the therapist and find out session by session that the therapist is not thinking critically of them and has empathy for them and compassion for them. And then it's like it can change on some fundamental level their internal experience of how people view them in attachment relationships afterwards. And it also can make the treatment a lot of fun, because when they're coming, instead of that anxiety is replaced eventually with gratitude, in my experience, if we're able to navigate this well.
Very much so.
Well, I want to make sure we hit all the things that you wanted to talk about this. Is there anything else kind of floating around in your mind that you wanted to get to?
I did want to just mention one of the, and I would encourage people to read it. One of the papers I sent to you was a 2020 review of current pharmacological agents for treatment of anxiety. It's an excellent paper that summarizes a lot of data, puts it into nice tables, and basically points out where the data currently is in terms of what's been supported, what hasn't, and talks about the pros and cons of each class of medication. So for those of our colleagues who are contemplating using medications to treat social anxiety disorder, that is an excellent paper to get a good overview of the pharmacology in this area in one paper, and I think it's 7 or 8 pages long. So It's a nice, concise source of data.
Do they talk as well about like how long people need to be treated on certain medications, like on like SSRIs? I think one of the common misunderstandings is like, how long do you need to be treated before it's effective?
Well, before it's effective, usually you see onset of some pharmacologic effects within a few weeks. There is actually a portion of the paper that looks at duration of treatment with pharmacology. And essentially it ranged from a low of around 6 months to a high of around 2 years. Because again, the point of the pharmacology was essentially to assist the person in engaging in therapy.
Wait,
Not
how long? Like
6
6
months
years?
to 6 months to 2 years.
2 years. Okay, because so they're finding for specifically for this type of issue,
Mm-hmm.
prolonged treatment may be more helpful because
Yes.
it gets them back into life more. And then that getting back into life maybe gives them a behavioral exposure in and of itself, right?
Yes. And then eventually they don't need the medication anymore. Now, the other use of medications is very transient, very temporary, which can be the two medications that have shown up mostly in that context are short-acting benzodiazepines. A person has to do something they know is going to be very stressful, but they really need to do it. Benzodiazepine, either single dose or a few doses, can help them through such a period. For performance anxiety, particularly where they're going to be doing something where they're talking, they're singing, they're playing an instrument or something, or they're doing an oral exam, low dose beta blocker propranolol can be very useful.
Yeah.
But again, it's usually a one-time dose, just for that thing that is going to provoke a lot of anxiety.
Yeah. I really have found good success in test anxiety, specifically with like propranolol.
Mm-hmm.
I think.
Yeah, at one time in my past, I used to be a board examiner for a while when psychiatry still had an oral board. And indeed, I am aware that a number of the people who were taking that board had taken 10 milligrams of propranolol before presenting. And indeed, in some cases, I told people who were going to take the board that they should, because in helping them practice, it was clear that otherwise their anxiety was going to impair their ability to complete the test successfully.
That's good. I think the other, well, I don't know if we'll have time to get to this, but just one other thought I had was, like, let's say you wanted to launch your own practice or go out on your own, go venture out in, the world of being a therapist or psychiatrist on your own, and you're in some sort of like group or something. If you think about it like a behavioral experiment, or think about it as like one of those things that you could possibly look at, write down what are the 10 things, aspects of it or more. What's the most anxiety provoking? What's the least anxiety provoking? And you could kind of create a behavioral journey and maybe get some therapy as well to overcome that. You can apply this to anything, which is nice.
Oh, yes. Yes, very much so.
You can apply it to any fear, anything that you feel like you need to do, but maybe it's just like, it feels overwhelming to do it. Whether that's like,
yeah, the behavioral hierarchy approach has a lot of utility. And even beyond people who are dealing maybe with anxiety, if you're just contemplating a new activity, like going out and building a private practice, if you make a hierarchy of, well, what things do I know I can do that I clearly have mastery over? What am I going to struggle with? What's going to be a challenge? And if you put those in a hierarchy, you can indeed work your way up and stand a much better chance of being successful, because you're much less likely to become overwhelmed during this process.
So great. This was good. This is a good discussion. Thank you so much, Dr. Cummings, for coming on. I know people really appreciate you. I get messages quite often of people's thankfulness that you're willing to come on and share your knowledge. So I want to reiterate that to you.
Oh, well, thanks. I appreciate doing this. I kind of enjoy it. I've, as I said, I've gotten over my fear of talking. So in fact,
Yeah.
yeah,
Maybe.
I think I may have reached that point where the trick is to get me to stop. You know?
Oh, no. I think retirement is like doing what you love and doing more of it, you know? So
Yes.
it's like, yeah, cut out the 50% of things that you just despise doing and see if you can just lean into those things that you love. So I'm glad this is one of those things that you love, because
Yes, indeed.
people love listening to you.
Well, thanks.
All right. Take care.
You too. Bye-bye.